So we've got two speakers here, Magda Raban, who we've already heard from, and she'll be talking about this as well, and Ms. Merchant, who's a clinical pharmacist and research officer in the Centre for Health Systems and Safety Research at AHI, in the Medication Safety and Electronic Decision Support Research Team. She's been practicing pharmacy for 20 years, and her current area of research relates to medication safety and electronic prescribing systems. So over to you, ladies.
Thanks, George. Okay, so today we've talked about a variety of medication errors, and generally when we think about medication errors, we talk about them in terms of the clinical error type, the procedural legal error type, and then talk about the potential harm to the patient and the actual harm to the patient. And we've heard presentations to this effect today already. And today when we talk about technology-related errors, we're going to introduce a new dimension to this flow as well, and that's the underlying mechanism of the error, and make the case that understanding the underlying mechanism or how the error occurred is important when we're talking about system optimization and how we can actually improve the effectiveness of these systems. So typically when we hear about technology-related errors, it's when things go catastrophically wrong or there are outages on a large scale that impact service delivery. However, in reality, technology-related errors happen very frequently and on a regular basis. So there's two recent systematic reviews that looked at technology-related errors in the inpatient setting, and some studies have estimated that technology-related errors account for between 6% and up to 78% of all medication errors after the eMM is implemented. So that just gives an indication that this is potentially an opportunity to improve the effectiveness of these systems if we want to make them safer. If we can eliminate these errors, then that can lead to substantial benefits. The other point these reviews make is that TREs persist even after several years post-implementation. So they're definitely not something that only happens in the early days as people are learning to use the systems. So what do we know about technology-related errors in Australia? So this study was done a few years ago now, and it looked at technology-related errors in 2 adult hospitals, and it estimated that 42% of all the prescribing errors after the introduction of the eMM were technology-related. And so that gives us, that just shows that if we can address these errors and understand how they're occurring, we can improve the effectiveness of these systems. So for this particular part of the study, we used all the data that had already been collected on prescribing errors as part of the research, and we were presenting the results from the 1 year post-eMM analysis. So this was a review of over nearly 9,000 medication orders, and within this there were 744 errors with minor potential harm and 209 errors with serious potential harm. And we had our clinical pharmacist team look at each one of these errors and examine firstly whether the error was technology related. And our definition here was that there was a high probability that the functionality or design of the eMM contributed to the error. In order to do this, the pharmacist had access to the orders within the system, so they could see how the orders were placed within the system, but also access to the testing environment in the eMM in order to be able to see how the system functioned when certain orders were being entered. And this also helped in determining how the errors occurred. So this is the underlying mechanism of the error. And we had a classification that we used for these underlying mechanisms, and you can see there were 7 broad categories, but under each one of these categories there is also a number of subcategories. And this classification was adapted from the one that had been used in the adult setting, and we'd added categories that were relevant in the paediatric setting as well for the errors that we were seeing in this study. Alison is going to take you through some of the examples of these errors in order to give you a feel of what these looked like. I will just mention that The category 7, so errors due to hybrid systems, was something we added because it emerged in the literature, from the literature, that this was often an important consideration when looking at technology-related errors. And we also know that in the Australian context, where we keep some of the prescribing on paper or have different systems operating within the same hospital, is something that's important to capture as well. And this was a category that could coincide with other mechanism categories as well. And when assessing each of the errors, more than one mechanism could relate to each error, because often there was a series of mistakes in the use of the system that would lead to the final prescribing error. Oops. So the last thing that the pharmacist assessed was whether there was decision support available 5 years post eMM to mitigate each of the TREs. So because we were looking at data that was a few years old on the types of errors that were occurring, and we know eMM systems are dynamic and change over time, we wanted to see whether the current build that was being currently used had developed in order to address some of these technology-related errors. And we used a classification from the literature to do this as well, which consisted of 4 broad levels of decision support, from restricted, so hard stops in the system, to 2 alert categories, so alerts with that require the prescriber to enter a reason, and your regular types of alerts, as well as guided decision support. So this is elements of the prescription being auto-populated, or things like the dose calculator. I'm going to hand over to Alison now, who will give you some examples of technology-related errors.
Thanks, Magda. So this first example, we won't go through every single category, just some illustrative screenshots here. So this first example shows what we mean by a selection error. And so a selection error can occur when you're ordering in the eMM, and it relates to picking a wrong drug or order sentence, often from a drop-down list or pick list. And in this particular case, the patient was being treated for a UTI, and the prescriber intended to select an IV gentamicin preparation, but instead selected and ordered nebulised gentamicin for cystic fibrosis. So obviously something that would not normally occur on a paper, in a paper situation. And you can see from the drop-down list there, often there's a lot of information presented to a prescriber at the point of ordering. And so these selection errors, they can also occur when a prescriber might construct an order from scratch or edit an order sentence. And they can occur in those situations when other elements of the prescription, such as route or frequency, may also need to be selected from drop-down lists. And so this next slide here is an example of what we might term a construction error. And so in our particular study, we defined a construction error as those errors that relate to sort of the free text elements of prescribing, as opposed to just selecting from a drop-down list. So for example, when these units are typed, they're just free texted there. And it's interesting, there's typing issues that come up in electronic systems as well. So we see mistypes of other elements in other areas of prescribing. For example, we've seen things like with patient weights, where a prescriber may accidentally type 8.6 kilograms instead of 6.8 kilograms, which in the paediatric setting, this has particular implications when that incorrect weight gets pulled into a dose calculator to calculate out a final dose. So we touched on this a little bit as well, but I'll go into more detail. So this is an example of one of our major categories relating to, we called it errors relating to workflow change. And so this is an interesting one, because when we examined the error data across the course of the study, we did see this particular pattern of errors that we saw in the electronic system that we did not see in the same way on paper. And so these were the wrong route errors, specifically relating to IV bolus routes. And so at first glance, you could think that this is a simple route selection error. But we looked at the practices for paper prescribing and then analysed all these errors sort of as a group. And then we also simulated the prescribing workflow in the test environment. And we realised there was a significant element of prescribing workflow change, moving from paper prescribing to electronic prescribing. And so, as we've mentioned, a previous common practice might have been for the prescriber to simply write IV on the chart and then how to give the IV may have been written on the chart by the pharmacist annotating some instructions, or determined by the nursing staff at the point of administration, or in discussion with the prescriber sort of offline. And in contrast, the paediatric eMM system, that design was designed with 3 specific IV routes. So you have IV bolus, IV continuous infusion and IV intermittent infusion, and they are listed alphabetically in that drop-down list. So we found that when a prescriber goes in and types just IV in the route search box and presses enter, or even just IV, if an option is not consciously selected, the system just defaults to that top IV option, which is IV bolus. And also because that's IV bolus is the top of the 3 IV routes, when in doubt, it may be the one that's just simply selected because it's at the top. So this pattern of IV bolus route errors is a large part to do with this change in workflow from paper to eMM. Now, I've just got one more example here of errors relating to workflow changes. And so just a bit of background. We've mentioned that duplicate prescribing was fairly significant as an ongoing issue in the eMM system. And so we were interested to analyse the underlying mechanisms of this error to see how these errors occurred. And so, as you know, the eMM system works differently to paper prescribing. And the system that we were looking at, there's various features. So it requires prescribers to get in the habit of clicking a button to refresh their view of the medication chart so that they can see the most up-to-date list of medications. And we also see with eMM, we know that 2 prescribers can, in different places in the hospital, can potentially access the same patient chart at the same time or very close in time. And there's also the use of standard sets or power plans in settings such as operating theatres or emergency, where they enable the ordering of a whole series of medications all at once, just with a few clicks. And again, there's features like a prescriber can right-click on an order and they can copy that order or cease and reorder or suspend an order. And these are all functions that you couldn't do on paper. So we're looking at all of these reasons for duplicate errors. And so back to this slide, this shows another example of one of these workflow changes. And here the prescriber attempted to make a discharge prescription, and we could tell this by the way the order was constructed and also information from the patient notes and the intention to discharge, and then a correct discharge script was created soon after that. So yeah, these underlying mechanisms here help us to understand what's going on with duplicate errors. And this one here is to do with the understanding about how to correctly create a discharge script. And so these are just a few examples to illustrate some of these mechanisms, and I'll hand back to Magda.
Okay, so what did the rate of technology errors look like in this setting? So this slide presents the technology-related error rate by the potential harm of those errors. So in the first column, you've got errors with minor potential harm and errors with serious potential harm in the right-hand side column. And you can see there circled in blue the error rate. So that's 2.42 errors with minor potential harm per 100 orders versus 0.87 technology-related errors per 100 orders with serious potential harm. And we're splitting up these results this way because often we tend to focus on the errors with serious potential harm when we're talking about medication safety. But when we're talking about technology-related errors, the errors with minor harm are also significant because they can point to functionality within the system that is causing a problem for clinicians when they're using it, and that potentially could be optimised to improve that. The other thing is, no matter the potential harm of the prescribing error, that error potentially also has flow-on effects for other workflows, such as the pharmacy workflow or the nurse's workflow in administering the medications. So it's important to take into consideration all the levels of these errors. And then we looked at the proportion of prescribing errors that were technology related, and this was between a third and a quarter of prescribing errors were technology related, and that proportion didn't vary much between the errors with minor potential harm or serious potential harm, as you can see indicated there with the blue circle. So what types of clinical errors were technology related? On this slide, you're going to see the top 3 clinical error types that were technology related, again split up by the potential harm. So for the errors with minor potential harm, wrong doses, duplicate drug therapy and wrong frequency were most commonly technology related. Whereas when we look at the errors with serious potential harm, that distribution changes slightly, and duplicate drug therapy errors take up a much higher proportion, accounting for almost 65% of those errors. We've also got there wrong route and wrong dose. Okay, so this is now the new dimension about how did those errors occur and the mechanism breakdown. Again, breaking those results up by errors with minor potential harm versus serious potential harm. And on this slide, you can see for errors with minor potential harm, errors relating to workflow changes accounted for the highest error rate in terms of mechanisms. So 1.25 errors were due to errors relating to workflow changes per 100 orders. However, there are also other significant categories there, such as errors due to system configuration and functionality, and selection errors were another prominent error mechanism type. When we look at, in a bit more detail, the subcategories within that category 6, errors relating to workflow, the top 2 subcategories were errors due to misuse of order actions on existing orders. So this is when a prescriber goes in and tries to edit an existing order or cease an existing order, and an error occurs in that process, and errors that occur when prescribing via an order set or a power plan. So looking at the distribution of mechanisms for errors with serious potential harm and the error rates there, you can see that changes slightly, but again, the most prominent category is errors relating to workflow changes. And the top 2 subcategories within this were again prescribing via an order set, as well as errors requiring new clinical knowledge, as provided an example by Alison earlier. So we thought we'd also pull out the mechanism for duplicate drug therapy errors, because these accounted for such a high proportion of all the technology-related errors, and in particular the errors with higher potential harm. So, and in these conversations around duplicate drug therapy errors, often the question comes up about, do we need to switch on duplicate drug therapy alerts? And that's something that many sites elect not to do. So, but if we look at the underlying mechanisms of these errors, we can then target the decision support to inform those particular mechanisms and mitigate the errors that way. So rather than implementing an alert across all duplicates, we can start to focus in on some of the main mechanisms. So prescribing via an order set was by far one of the most common mechanisms here, but you can see things like hybrid systems also contributed, and this was largely to do with the use of eMM and paper charts, and things like errors with an associated task or reminder. And again, that's a lot of the time to do with a hybrid system where there has to be a placeholder entered onto the eMM, so that to alert the user that there is also a paper chart. There were also errors related to failure to view the updated medication profile. So this is those refresh errors where the prescriber must refresh the display in order to see the new orders they've placed appearing on that chart. The next step was that we looked at, was there decision support available 5 years post eMM to mitigate each of these technology-related errors, and 27% of all the errors that were identified, irrespective of their potential harm, had decision support available in the build at that time. And the level of decision support was predominantly guided with some alerts as well, and that's a positive thing to see, because we want to obviously minimise the number of interruptive alerts that are used in the system and defer to using guided decision support where possible. So we thought it would be useful if we went through some of the examples of the solutions we saw to some of the technology-related errors, and Alison will take you through that now.
Yeah, so as Magda said, I'm just going to run through some of these examples to illustrate possible solutions used to mitigate some of these error types, and I'm going to link back to those previous error examples. And so this is a targeted alert, and I guess they can be used quite specifically at particular prescribing points and for particular TRE mechanisms. And so this is just an example of an alert that occurs when units are free texted or typed and is triggered during the prescribing process before sign-off of that order. And so it's been programmed to trigger if you type GM, for example, or perhaps if the system doesn't recognise the unit, or if the units are omitted entirely from the order. And it just prompts the prescriber to stop and pause and have a second look at what they are typing. And so it's targeted to that kind of construction error we saw before. In thinking of the sort of workflow change error example we saw previously, one of the solutions might be to restrict the number of routes available, and this again can apply to different selection types of errors, but the principle's here. And so here's two examples. Vancomycin here has IV bolus removed from the drop-down list, so it can't be ordered in that way. And vincristine is restricted to having only 2 routes available to help reduce instances of route errors with this high-risk medication. And so consideration, of course, can also be made to reordering drop-down lists to mitigate these errors. So, for example, you might make changes to ensure that high-risk medications or high-risk routes even don't come high up on the list. Now, we have other alerts that can prompt or guide prescribers in ways to reduce duplicate prescribing. And this is just an example of an alert to prompt a prescriber to stop and perhaps refresh their orders list or recheck the most up-to-date version of the electronic chart before prescribing. And again, here's another example of an alert that can appear when 2 prescribers are both accessing the patient chart at the same time. And I'm thinking of a situation where you've got doctors on a ward round, changes are being talked about for that patient, and it may prevent 2 doctors prescribing those new medications or those new changes on different terminals at the same time, that type of situation. And finally, this is just an example of, we didn't have any hard stop alerts in our data, so this is just an earlier example, but this is just to show you what a hard stop alert would be like, and you tend to want to not put a lot of these in the system. So in the paediatric setting, there's a dose calculator tool, as many of you are probably aware, and so it uses the patient's height or weight or other parameters to help you accurately calculate out a final dose. And we could interestingly group patterns of errors together that relate to the use or misuse of this tool. So in this particular situation, if the tool was bypassed, originally it was possible to sign off on an order without having that final dose calculated out. With this alert, if you now attempt to sign off on this order, it stops you and you actually can't proceed further, and it redirects you back to the dose calculator and it can't be overridden. So that's a sort of example of a hard stop alert that you might want to consider. So these are just a few examples of sort of system design possibilities or changes that can be made to optimise systems, but in a really targeted way. So if you actually know the underlying mechanisms of some of the errors, you can be very informed and specific about those changes, but it also may help you be more informed about specific areas for training or targeting groups of people that may be implicated in these errors. So I'll just hand over to Magda to conclude.
Okay, so in conclusion, understanding technology-related errors is important for eMM optimisation, so particularly because they account for a significant portion of errors after eMM implementation. And in this particular study, we saw that was around the 30% mark, which is lower than what we saw in the adult setting, which was around the 40% mark. But the underlying mechanisms are really important to understand, because that's where you can actually see where system changes can be made, or where more training or support is needed if those changes can't be made to address those particular errors. We do need more work on identifying technology-related medication administration errors and where the system doesn't support that administration process as effectively as we'd like to see. And the next steps for this part of this work is to examine the longer-term technology-related errors as well as those at the second site. Okay, thank you.
Thank you. I'll just ask our panellists to work their way down here, and while we do that, we've got a few questions. Got a question here?
Lillian from eHealth. Wonderful presentation, thank you so much. I think there's a lot there to think about, especially in the way that we could perhaps support the system to support prescribers a lot better. Your last point on administration, I think, would be a really interesting area to look at, because I feel in our paper world there was a lot of scope for administration errors to take place, particularly with the lack of standardisation in the way prescribers prescribed, or abbreviations that were used that were inappropriate, or even just their messy handwriting, really. No offence to any doctors out there, but is there any scope for some work to see perhaps how technology has positively impacted some of those administration errors? So we did present earlier today on medication administration errors, and we do have that data set as well to look at, and so we can look at that in a little bit more detail. For administration errors, there's also, you probably need to take into account not only the eMM but other contextual factors as well. So we'll be limited in that regard, but definitely we can look at whether the eMM supports a nursing workflow and how efficiently that is done through what we've recorded in some of the procedures. Yes, yeah.
So here, I guess one other issue, of course, is that technology procurement isn't done by the people who are implementing the eMM. So often the systems that are put in place aren't ideal for or fit for purpose. That's a discussion point.
Hi, Reece Thomas from John Hunter. You pointed out that a number of errors were related to the change in workflow. I guess with those, how do you distinguish between some of them are major issues that need to be addressed, and how much of them will kind of be fixed automatically through a learning effect or the development of workarounds and those as people get used to the system over time?
Yeah, well, I guess we're looking at data 1 year post eMM. So, hopefully most of those initial, we do have data also from the early phases of the implementation, so we can compare and see, what changed between those early phases to 1 year post eMM. And then I guess it is about priority setting and, looking at the potential severity of the errors, or errors that are occurring very frequently can assist with that priority setting. Yeah.
Squeeze in one last question.
Hi, Regina, Fred IT. It's a great presentation, very interesting. I'm obviously involved in the tech and software space, so just wondering how you provide that data and feedback back to the software companies to put that in their roadmap to improve features and functions, and also the role of AI to help with reducing medication errors.
Okay, so all these results were fed back to the steering committee, of the hospital, and much of this work did result in changes to the eMM. So we put forward recommendations of, I think there was 6 recommendations for what could be changed to help mitigate some of these errors. So that's at the local customisation sort of level. I guess feeding back to the vendors in this case is a little bit trickier from our perspective, but yeah, that's always something that we'd like to do, and I guess later on you'll also hear about some of our the Health Innovation Series, which will hopefully support that process as well. Yeah.
Thank you. One reflection I would make is when I first started in medicine, we had no idea what workflow was. So at least with digitisation, we actually started capturing the concept of workflow. So that is probably an unintended consequence of digitising. Please join me in thanking our panel, our speakers.